Thank you very much, Mr. Chairman. Good morning, ladies and gentlemen, friends. I'm so happy to be here at Cairo. My sincere gratitude to Dr. Ali and the organizing committee for preparing this APCSS this year. My topic is same, the cervical disc arthroplasty, and to make the better arthroplasty, how we can do the surgical techniques. This is my disclosure. So I'm going to briefly mention about some indications and contraindications regarding cervical disc arthroplasty and potential the unique complications related with arthroplasty and key surgical elements and so on. Regarding cervical disc arthroplasty, as the previous speaker mentioned, when you check at Google, you can see more than 40 the arthroplasty implants are available in the world. So I'm not sure which implant will survive or disappear in the next 5 or 10 years because up to present, I think no ideal cervical disc arthroplasty devices which can perfectly mimic the natural cervical spine were invented so far. So there are a bunch of problems regarding the ACDF at the index operated level or adjacent level. As you can see here, we see screw fracture and cage subsidence and instrument failure on your right hand photos. And sometimes we see so-called ASD at the adjacent level after cervical arthroplasty. We were able to publish the good result regarding the single level ACDF with standalone cage versus arthroplasty using active C. So we found relatively good surgical results at the post-op 2 years, as you can see here. So we concluded this is going to be such a promising procedures in terms of motion preservations. So what about the indications in cervical disc arthroplasty? It is well known, the radiculopathy, myelopathy, or sometimes myeloradiculopathy. It should be only 1 or 2 levels in the levels of degenerative cervical disease from C3-4 to 6-7. This is the recommended the guideline from NAS so far. Now what about the contraindications? Severe instability and the cervical spondylosis and so on will be contraindications of the arthroplasty. So I can summarize. There could be some potential benefits of cervical disc arthroplasty, such as motion preservation and reduced ASD, and the potential complications regarding the related with the ACDF. So, what are the potential complications in the cervical disc arthroplasty? In addition to the usual complications related to ACDF, we see some unique complications, such as HO, heterotopic ossification, osteolysis, and improper the implant's position. It is notable that in many literatures, within post-op 1 year, we see almost 12% of patients were reported to have the mechanical or bone-related complications after cervical disc arthroplasty. Due to the time limit, I'm going to mention only 3 specific complications related with arthroplasty. The first one, HO. Second one would be the osteolysis, also called anterior bone loss, and improper the positioning of the implant. Regarding the HO, it is well-known kind of complications. The incidence varies from 7% to 70%. It is also the bone breaching ossification adjacent to the operated level. And according to the Korean groups, the old age and male sex are the risk factors of HO development. Fortunately, usually this HO rarely causes symptoms to the patient, but when we meet severe and progressive HO, it may defeat the original purpose of motion preservation of the arthroplasty. So, to reduce the HO, it is recommended to minimize unroofing cancerous bones of the end plate and use the copious irrigations and use of NSAID at least post-op 3 months. And what about the osteolysis? The mechanism of the bone absorption is not entirely understood yet. Some papers recommends the foreign body reaction or wear debris effect may be the cause of the osteolysis. And as you can see here, the osteolysis can happen above and below any places of the operated level. But originally, the name was adapted from the anterior bone loss because it was noted first at the anterior edge of superior vertebral body of the operated level. And also, fortunately, this osteolysis rarely symptomatic. According to this paper, they found in the almost 200 cervical disc arthroplasty, the bone loss was identified in 63%. And they concluded the greater the number of levels operated, the higher risk of the ABA, anterior bone loss. So, and fortunately, they also concluded the development of anterior bone loss has no long-term effect on the mechanical function of the arthroplasty and necessity for revision surgeries. So, usually the osteolysis develops within the first post-op year, and we need the close radiological follow-up because the additional failure may produce the segmental kyphosis and implant subsidence. And lastly, we can see a lot of the improper positioning of the implant, anterior migration, posterior migration, and this improper positioning may produce unilateral the radiculopathy to the patient. This is one of my cases. This patient underwent arthroplasty 2 years before in the other hospital. As you can see in the X-ray and CT scan, the implant is located off midline. Because of the progress, right shoulder and arm pain, we have to convert to the ACDF in this patient. And severe displacement of the implant can be noted in many literatures. And interestingly, the sagittal split fractures can happen in the use of killed prostheses, as you can see here. So what are the key surgical elements for a better cervical arthroplasty? First, I think the indications and contraindications are most important. Then the proper patient position and plate preparation and proper implant size and positioning of the implant would be the key elements. First, using the fluoroscopic C-arm image at the beginning of the surgery, we need to place the patient in the normal and slight lordotic position and use the useful landmark for the midline of the vertebral body would be very crucial. So we need to keep in the midline of the vertebral body, and we need the symmetric decompression, adequate decompression to avoid the postoperative unilateral radiculopathy and proper end plate preparation. Do not do over the preparation, not to disrupt the end plate, upper and lower. And what about the appropriate implant trial? And finally, proper implant size would be important. According to many literatures, the ideal size of the implant would be, should be the height similar to the adjacent normal disc, and it should provide as much surface coverage of the operating level. And the correct centered positioning of the implant sagittally and coronally would be also important. And finally, if it is unable to implant successfully, you had better convert to ACDF without any hesitations to do the arthroplasty. Regarding the ideal size and positioning of the arthroplasty, actually, there are not so many papers regarding this ideal size and position in the literatures, but I think, the optimal position would be centrally placed, both in sagittal and coronal planes. And you can refer many kinds of the proposed algorithm for the revision surgeries, as the previous speaker also mentioned. So this is my conclusion. Cervical disc arthroplasty seems to be very good surgical options in a well-selected patient with good indications. And we need to adhere to the strict surgical indication, contraindications, and the appropriate patient selection and attention to the many surgical techniques would minimize the unique complications in the cervical disc arthroplasty and maximize patient benefit after operations. Thank you very much for attention.